Good morning. You've almost made it to afternoon, and I want to encourage you to continue to enjoy your lunch. I hope that as a result of hearing Charlie earlier, you've been inspired to engage further with the center in our work as we work to provide some pathways to solutions to some of the things that you heard about this morning. I know I was just part of a tremendous workshop on prescription opioids from a pharmacist's perspective, and hearing the complicated fabric of our medical community and how things layer one on top of another. It's imperative that even those of us outside of the medical community begin to understand how we can help assist in building social and cultural fabric, in supporting reduction in stigma, and supporting people who are trying to get into recovery. I want to take some time to thank our partners and sponsors of the conference. We are really grateful to you all for your partnership, especially in sponsoring the conference. Those sponsors are Anthem, Emergent Biosolutions and Narcan, HealthLink, Fairbanks Addiction Treatment and Recovery Center, Indiana University Grand Challenges, IU Health, Indiana University School of Social Work, Indiana Office of Community and Rural Affairs, the Lilly Endowment Incorporated, Overdose Lifeline, Safe Haven Recovery Engagement Center, Rethink Tobacco Indiana. Can we take time to thank all of those partners? And I hope you have been enjoying this fabulous food that has been provided by many, many hands. Can we take time to thank our servers and the cooks who provided this food to us? We have an incredibly robust and innovative engaged teaching program that we call Sustaining Hoosier Communities. And Sustaining Hoosier Communities is our deep dive into one community every year. Last year we were in Lawrence County, and this year we have been in Orange County. And the number of students, faculty, and community members who get to be engaged and share ideas and create solutions together is really astonishing. And in responding to these community-initiated ideas for solutions to their own communities, we at the center and our students and our faculty are able to learn from community leaders who are on the ground and know what best happens in their own communities, and to be able to adapt our own teaching and learning models to what it is that communities can teach us and what we have to offer those communities. One of those initiatives has been our rural nursing outreach program, where we had students go into the homes of patients who, some of whom had not been seen in years by their primary health care provider. Now we have done more than 480 home visits just in Orange County, which is astonishing. And we want to share that story with you in a video.
So going into the experience, I really didn't know what to expect. Especially going into a rural area for me was a little different because that's not the kind of setting that I grew up in. I wasn't really used to it. But once we started, I realized that a lot of it was just, talking to people and helping them as best you can, and it was a really great experience. We would take the drive down to Paoli, and first we would all meet together. And so then we would kind of set our goals for the day and discuss each of our patients and what we think the best course of action is, and discuss that as a group.
A patient that had chronic pain, severe chronic pain, his depression was overriding that. And he's like, I can deal with pain, I can't deal with this depression. And I do think it's tied to lack of employment, isolation, anxiety. It's tied to all those things.
Well, I actually come from a rural community, and I grew up on a farm, and I plan on staying in that area because I do feel like it is underserved and people don't understand that way of life sometimes. So I plan to work with the rural community. The best thing was working with the physicians. They had a lot of good things to say about each other. They understood where they came from, whether it was a lower socioeconomic status or just the health problems in general. They wanted each other to do better.
I really enjoyed the sense of community that there was. I could see how everyone knew each other, and there was definitely a sense that everyone cared for each other's well-being. I thought that was really nice to see. One of the things I like about nursing is that there's so many different avenues that you can go down for it. So public health is a major interest of mine, and that clinical really solidified that for me. I do think I want to work with more rural populations and underserved areas.
Working with the IU Center for Rural Engagement, it has opened my eyes and made me realize that the rural community does need more doctors, nurses, social workers to work with them. It's made a positive impact.
Our thanks to Emily Jones, who put together that wonderful video for us. Emily is yet another one of our students who helps us tell the story of our work in rural Indiana. Next, we're going to hear perspectives from professionals in Indiana working to address issues of addiction and its impacts on our families. Please join me in welcoming our moderator and Indiana University's Associate Vice President for Research, Faith Kirkham-Hawkins, Hall-Render Professor of Law at IU McKinney Law School, Nicholas Terry, IU School of Medicine researcher, Angela Campbell, and family physician, Dr. Yolanda Yoder.
Good morning, everybody. Is anybody else noticing the chairs are incredibly short when you first sit in them? You feel like you're at the kids' table every time you sit down. So let me first, before we start, ask folks to introduce themselves, just tell you a little bit about themselves. I'm Faith Kirkham-Hawkins, as Carrie mentioned. I'm with the Office of the Vice President for Research at IU. And I have the great good fortune to work very closely on the Addictions Grand Challenge as well as the others. And the reason it's a great good fortune is often what I do is several steps removed from impact. And this one, as you'll learn, is focused on impact. And actually, I go home at the end of the day feeling that I might have done a little bit of good, which is not always the case as an administrator. So I'm happy to be here today. Yolanda, why don't you introduce yourself?
So my name is Yolanda Yoder. I'm a family practice physician in an organization called Southern Indiana Community Healthcare. We have 4 offices, and actually one of them is in West Baden, French Lick area here. One's in Paoli, and then 2 in Crawford County. And it's an organization that is independent, has been in business for 45 years, and started at the funding of a Robert Wood Johnson grant with a group of nurse practitioners and physicians who wanted to serve a low-income area. And it's been really interesting as they made their value statement and their mission statement. They were so relevant then, and they're still very relevant now, to reach beyond not just our patients' immediate healthcare needs, but look at the community in general. And so that's what some of our recent topics today are going to be about.
Angela.
Hi, I'm Angela Campbell. I did my master's in public health at Columbia University, a PhD in health policy at Penn State, and now I'm really happy to be here in Indiana. I'm working as a postdoctoral research with the IU School of Medicine. Our project is on neonatal abstinence syndrome. Neonatal abstinence syndrome is a condition that affects newborns when they are born to opiate-addicted mothers. So once they're born, they go into withdrawals, and we're researching the best way to treat them and the best way to help these infants get on a healthy path in life. So.
Great, thank you. Nick.
And I am Nick Terry. I am a professor of law at IU McKinney School of Law, where I am the director of the Hall Center for Law and Health. I specialize in healthcare law and health policy, and was happily working my little way around doing various types of health information technologies and so on when this big hook appeared from the Vice President of Research's office, and now I'm opioid guy. It has been an incredible honor to work with the folks on the Addictions Grand Challenge, and I, believe me, have learned far more than I have contributed.
That may be up for grabs, but we'll get to that later. So let me start, just in case you're not familiar with the Grand Challenge, to just orient you a little bit. And so the first question is, what's a Grand Challenge? And why is it different from the other things that a university might do? And so first and foremost is that it is impact focused. We've all heard the metaphor of the university as an ivory tower, which is separated from its communities. And we have great faculty members doing really important research on stuff that will matter in 20 years. And that's really important. That's how we learn. And that's how science advances, by not caring whether it's going to advance next week. But we are a public university, and we need to pay attention to public. And so we are engaged in a grand challenge, in 3 grand challenges that are about public impact focused research, about doing research, education, and community engagement in ways that will benefit the communities of Indiana and more broadly the nation. The second thing is that it's transdisciplinary. Another one of the sort of standard stereotypes of the university is everybody's in their silo, doing their thing, and not talking to people who are in the silo next door studying the same problem from a different perspective. And that's something we are trying very hard to combat with the grand challenges, by bringing people from different disciplines who study things in different ways together to talk about the complexities of those things and how to solve them, because very few of the big problems can be solved from a single viewpoint. In fact, I would argue none of the big problems can be solved from a single viewpoint, and the grand challenges get that. And third, we are evolving. This is what is making my hair go gray. I have a really good colorist. What this means is that we're not entirely sure the direction we'll be going in a year or two, because we need to be responsive to the challenges as they develop in 2 ways. One is when our researchers and our faculty members and our community partners find something, we need to be able to capitalize on that and not say, well, you didn't originally ask to study that, so you're out of luck. The other is when we see the crisis on the ground changing, we need to be able to respond to that. And so one example I will give you, this is not news to most of us, but it may be. You will notice the title of our grand challenge is Responding to the Addictions Crisis, not responding to the opioid crisis. And that is because we recognize that opioids are merely the drug du jour, that the broader issues that undergird the crisis of addiction we are facing, if we just stopped opioids in their tracks, we would have a different addictions crisis. And we know now methamphetamines are on the rise again. There are other drugs that we have not even begun to dream about. So we have to evolve in response to that. We are, in this case, responding to the addictions crisis. The statistics about it are news to no one. It's in the news a lot, but it is particularly horrific in some of our rural communities. It is particularly shaped by the things that contribute to the social determinants of health. Addiction is not merely a one-faceted thing, and so we are paying attention to that. One little factoid that is, sometimes it is hard to get people to care if the problem is faced by folks out there. And a lot of the people that I want to get to care are the people with money to help us do something about that. And so a point that we bring home again and again is the addictions crisis is costing us money. Over $4 billion in each of the last 2 years just in Indiana. And that is crazy. Imagine what we could do if we could stem the tide. And so we work on that. So the actual Grand Challenge is a partnership with Governor Eric Holcomb and the state, with IU Health and Eskenazi Health, and literally dozens of community organizations across the state who are on the front lines of trying to stem the tide. And it is those partnerships that will enable us to do something. If our research stays on campus, not much going to happen there. But if our research is going out into the communities and informed by the communities, then we have the opportunity to do some good. It was announced last October of 2016, and we have 32 projects that are working their way through the process, 2 of them represented by Nick and Angela, and one of our community partners who What Are We Learning From You? By Dr. Yoder. If you look at the crisis, you will see by this map, you will see the data is a little bit dated. Nick told me that new data came out this weekend, which I did not look at. But we can see some patterns that rural communities, although some are in the worst case scenario, there are large swaths of areas that are equally that are sort of a concentration, even though they might not be in the highest rate of the problem. And we were talking over lunch about the fact that counties don't, or problems don't observe county lines. So if we had one isolated county that was in trouble, we would have to work with that differently than if we have a region that is in trouble, and that's what we're facing with the addictions crisis. One thing I want to have folks understand about our model, because it shapes what we're doing, is recognizing again that addiction is not a single-faceted problem. We use the socio-ecological model of addiction, which basically says, and I'm going to dumb it down because I'm not a scientist, so that's my stock in trade, is dumbing things down. Any single addiction is the result of a complex web of factors ranging from the personal, biological, psychological, through the family system and the local community, your social networks, through the town and county that you live in, up to the level of social policy, state law, federal law. Let me give an example of what I mean by this, because this is how I came to understand it. I was in every way predisposed to be addicted to tobacco. My parents smoked like chimneys throughout their pregnancies with their children and my childhood. I did not realize that you could walk into a house and not have it be foggy until I was about 15. When I was about 15, I chose to get rid of the middleman Instead of having secondhand smoke, why not have firsthand smoke? It must be so much more high quality. And so I started smoking myself. I was immediately friends with all the smokers. We would find each other and smoke together. That was my social network. I lived in a place where you could buy cigarettes from a vending machine. So we were in a community and culture where smoking was easy to do, where state laws and federal laws did not discourage me in any way from smoking. So at all these levels, my addiction was a given. And it wasn't until there started to be change at the majority of these levels that I was able to get that addiction under control. I will not say I am not addicted to tobacco. There is ample evidence I am, but I'm able to get it under control, but only because laws changed, the culture changed. I don't know anybody who smokes, so my circle changed. Even my parents quit. All of that, so that now I have more resources for dealing with that. That's how all addiction works. And IU is trying to be aware of that as we move forward. Last slide, and then we'll get to talking, is for IU, we recognize we don't want to do what others can do as well or better, but there are areas in which we can do good work, and we identified 5 of them. One is data analysis and sciences. There's a lot of data, but not much information. And so we're trying to bridge that gap between data and information, okay? Another is education, training, and certification. We have the largest medical school in the country. We have outstanding nursing, social work, public health programs. We also have lots of good educational outreach, and we're trying to make use of that and bring that education to communities that need it. So that's a second area. A third area, which is the big complex one, because it just is the basket that contains so much, is basic translational and applied sciences. That will run everything from mouse models of addiction to treatments that we're trying in clinics and hospitals and in schools, hands-on activities to try to reduce the likelihood that teenagers will start using substances like marijuana, alcohol, tobacco, and opioids. A fourth one is policy, economics, and law. He's our guru on that, helping us understand how policies and laws are barriers to resolving the challenge. And our fifth one is community and workforce development. And we see this as really crucial and admittedly our weak spot because we've not been as good at working with communities as we should be as a university, which is why we're so excited to partner with the Center for Rural Engagement and other organizations at IU. So that is sort of the broad overview. We wanted to talk a little bit today about one of the areas that we feel most strongly about. It's one of our goals, which is to reduce the number of babies who are born suffering from the effects of neonatal abstinence syndrome. And so we're going to focus there with some discussions of policy as well. But first, I want to go to Nick. I threw up a slide. I recently read that in 2018, it looks like the number of overdoses from opioids dropped somewhat from 2017. So are we on the far side of the problem?
Yeah, it's all over.
Oh, good.
Mission accomplished. We'll land on the carrier and celebrate. There has been nationally about a 3% drop in overdose deaths, opioid overdose deaths. There is overall in Indiana about an 8% drop in overdose deaths. That is only a large number if you're not the family of one of the 92%. Just as those numbers have decreased, remember those are death numbers. That means we're getting better at finding people just before they die. That probably means that naloxone is finally really showing itself in the statistics. That doesn't mean that we've made much of a dent in the opioid addictions crisis. We still have huge numbers visiting emergency rooms, at least they're emergency rooms, not mortuaries, more and more. But as Dr. Hawkins mentioned, we have a crisis or a series of crises. In fact, you can date it back a century if you really want to go this far as the number of addictions crises we have. We are seriously in a fentanyl crisis, a synthetic opioid crisis, and you've probably all seen the meth numbers as well, coming up quite strongly. Emergency room visits for meth are up to incredible numbers in Indiana. Plus, there seems to be a never-ending supply of cocktails based on various drugs. So we're a long way from, I think, even flattening. I get very worried when I see I joked at the beginning with mission accomplished kind of ideas, but I get very worried because when people start saying things like that, the money dries up, and the federal legislation, federal budgets start going flat or start going in decline. And we are so far from putting in the kind of medical healthcare structures, social work structures, and resilient structures that we need to handle not just opioid overdose deaths, but all forms of addictions.
Yolanda, from the perspective of a clinician in Paoli, does Nick's observation jive with what you're seeing, and can you sort of bring it into focus for us?
Well, it's difficult on a one community level to draw any large conclusions. What I can say is that we are now talking about it openly, where in the past, over the years, we would have people in our clinic who we had not necessarily even asked whether they were using, but especially in the maternity area, we started doing urine drug screens probably about 4 years ago, just simply because we realized that we could not ever determine who was going to be affected by it. And we had a year that we had 27% positive drug screens, and that number has not gone down, but now we ask about it and we talk about it. We say that it's safe to talk about it. So it's moving into the light, at least, in a way that I think we are much further down the road in terms of making an impact. So there's a lot of reasons for hope. And as we recognize that people are feeling safer to talk about it, that's only going to enhance the engagement, we hope, in the treatments.
So what you're getting at, I hope, is perhaps one of the things that we all know is crucial and a huge barrier is the issue of stigma. That people are afraid to acknowledge that they have a problem, that stigma becomes a barrier to their getting help. And so if the more we talk about this and the more we say better to safely discuss something than to keep it hidden, that is at least some reduction in stigma and some increase in treatment, we hope, as a result.
Yeah. It is, but this is an area where I think the rural communities have an additional hurdle in that stigma is something that when you live in a small community and you want help, and yet when you go to the doctor's office, you know half of the people that work there, there's an extra measure of courage that it takes to take that first step. And we, as a community, are working towards that in a number of ways that we can go into later, but that is a definite difference for rural communities that is not present otherwise.
Absolutely. Angela, Yolanda mentioned that at one point 27% of expectant mothers were coming in testing positive for drugs, which, was that all drugs or? Sorry.
So that was combination, more marijuana than anything else, and then opiates, and then we had a few that would have meth. And some with Suboxone, some with methadone, rarely, but by far away was the marijuana. And then our smoking rate is 30% of our pregnant moms are smokers.
Still, wow, okay. So, Angela, you are looking at particularly the children of those moms who come in. So back up a step, you gave a little bit of an introduction into what neonatal abstinence syndrome is.
Yeah.
Can you say more about what neonatal abstinence syndrome looks like?
Yeah, so I want to say, so to me, as a researcher, women's health is infant health, because so much of what happens to the mother before she gets pregnant impacts the pregnancy and the child's outcomes. So from a public health perspective, I think it's very difficult to separate just the infant from the mother. And a lot of times in our health system, we don't really get interested in women until they become mothers, until they become pregnant. And especially with this addiction crisis, I think we really have to target women and start talking to them even before they get pregnant, because about 20% of women on Medicaid filled a prescription for opioids. It's been found. So these women may not even know that they're pregnant and they're exposing their infant to opioids. So, and some of them are, I mean, these are prescriptions, right? So it's seen by a doctor, but we don't actually even know the effects of just exposure, not even addiction. So it's been found that just taking an opioid while pregnant can be associated with developmental delays once the child is born. So neonatal abstinence syndrome is a specific condition that occurs when the mother is a chronic opioid user. And unfortunately, when women who are chronic opioid users become pregnant, actually it is agreed upon by the medical community that the best form of treatment is not for her to go cold turkey and suddenly stop taking the opioids. Instead, they transition her to a different opioid like buprenorphine or methadone to help ease the cravings, because what they've found is that when you take these women cold turkey off of an opioid, they get very sick, and often it leads to worse drug-seeking behaviors that harms the infant even more. So it's a harm reduction approach to the pregnancy. And so that's what I say about backing up and saying women's health is infant health, and trying to treat addiction before the woman becomes pregnant is key. But once the woman becomes pregnant, the party line is that we go with harm reduction and methadone, I think. Yeah, I defer to the medical doctor. Yeah. So what does neonatal abstinence syndrome look like? So when these children are born, keep in mind they've had a steady stream of opiates for the 9 months that they've been gestating. And so once they're born, they're no longer getting that steady stream of medication. And so you see withdrawal symptoms, you see diarrhea, tremors, sometimes seizures. They are inconsolable, they're hyper irritable, they cry all the time, which is saying a lot because newborn babies cry a lot anyway. And it's very difficult for a mother who's also opiate addicted, right, to care for this infant. And so what they often do is they begin opiate weaning for the infant. So the infant receives small doses of methadone to try and wean them off of opiates.
Okay. So I guess when I started the work on this Addictions Grid Challenge, I had never heard of neonatal abstinence syndrome. It wasn't something that I knew much about. I knew about fetal alcohol syndrome. We know so much about fetal alcohol syndrome. I'm getting the sense we don't know nearly as much about the long-term impact of neonatal alcohol or neonatal abstinence syndrome.
That's absolutely true. So one of the goals on our research project is actually to track these infants that were born with neonatal abstinence syndrome and look at their long-term outcomes. There's evidence that a lot of them have developmental delays. We're not really sure what the full impact is, what percentage, or how profoundly delayed they are. So hopefully talk to me in a year or two. Maybe I'll have more answers.
I want to open us up to questions shortly, but before we go there, I'm thinking about the complex everything. We've all heard about the nature-nurture debate. I'm thinking about the complex situation into which any child is born. It's their prenatal health. It's the family circumstances into which they are born. It's the potential for adverse childhood experiences, which of course neonatal abstinence syndrome would be another one of those. So how do we, is it possible to sort of sort out, or do we, oh, this is due to the opioid exposure and this is due to something else? Or does that merely say we have to take a whole social determinants, very broad approach? That wasn't meant to be rhetorical.
Yeah. But that's been a hard one to answer, in that so much of the social science that we have now is still evolving. We had a conversation a couple days ago, and she was saying that we don't even know whether going through neonatal abstinence syndrome is going to be an actual ACE score as well, that may be so impactful that would be an additional one to add to the questionnaire. So the complexity is such that we need to keep our eyes open and keep our sense of identification of what's going on and our responses to it, and keep communicating to all of the partners on the teams in order to start teasing apart how to respond to the complexity. In our office, we've had the opportunity to add a number of what we would consider services that we thought were going to be very helpful. We have integrated behavioral health care in our office now, and so when someone is identified as having depression or anxiety or something going on, I can walk down the hallway and bring that behavioral health counselor into the exam room and do a warm handoff, which has been shown to have a much lower no-show rate than if I had sent her to a community mental health center and she had to wait a couple weeks or a month. And in that kind of impact rate then and there, we feel like that's a positive thing. Another program we have is that we're doing ACE scores on all of our moms, and about 31% of our moms have an ACE score that's 4 or higher, and equally divided.
Can you tell me what that means, because I'm not entirely sure.
Okay.
Thank you.
Yeah. So adverse childhood experiences, the research done in the 1990s by CDC and Kaiser Permanente staff, who identified 17,000 patients who they gave them a questionnaire to look at what some of their childhood experiences have been. And it was a broad health questionnaire, and those questions were peppered in there. And then they also looked at some of the health outcomes of that group. And out of the research that came from that, it showed that just about every major health condition was negatively impacted by having a score of 4 or higher. For instance, a score of 4 or higher, they're 8 times more likely to have an addiction, twice the amount of heart disease, life expectancy of 20 years less if they had a score of 60 or higher. And all of those environmental impacts affected the developing brain, the dysregulation of the brain, in a way that those children then had a hyperstimulated environment that affected cardiovascular health, cancer risk, just numerous variables. So as we look at that, again, trying to figure out what is the complexity that's going into why someone begins to use a substance, we know that the ACEs score has an impact on that. It's not their destiny, but it can have an impact. And we look at that then to say, what can we do to make a difference? So then as those ACE scores are identified, we have a referral program. We refer either to our mental health person in-house who's trained in trauma-based therapy. You may have heard of EMDR, which is eye movement and desensitization and reprocessing. That's been shown to, it almost sounds magical, but to move the intensity of that experience out of the part of the brain that experiences fight or flight and move it to an area that's more of a thoughtful processing part of the brain. So to non-surgically do something like that can create a healing environment for that person. So to have that in-house has been a service that we offered. There's a support group that IU Health Paoli Hospital has 2 of their nurses that come to our office and do something called The Village. That's a support group for moms. They didn't have to be in recovery. They could be just any moms who were having a tough time. So we built these things into the system thinking that we were going to be making a difference. Another one was the Nurse Family Partnership that many of you may know about, that a mother who is first-time mother can have assigned to them a nurse who is their personal nurse for home visits from that point on until 2 years after that child is born. And it's been shown to have amazing outcomes as that support and relationship nurtures that mom through some really difficult times. So that program was implemented last fall. And would you know that we have the toughest time getting anyone signed up for that program? It's right there. We have a tough time getting people into the Village support group. It's right there. We have a tough time getting people to say yes to the therapy. That's right there. So there's something else behind this all that we can't quite identify what it is. Like, why do people say no? Is it a safety issue? I'm convinced that meaningful relationships are a piece of it, and as a family practitioner, we try to be there and be a place of trust. And they come to know us. Some of them grew up, some of them I've delivered, and then 25 years ago, and now they're my patients again for their delivery. So we feel like we have trust there, and those women tend to do better. Some of are new to the practice. But there's still something ongoing about the suspicion of someone coming in to help me. I don't think that I want that. Are they going to judge me? I don't want that. So there's some research that could maybe be done on why people say no to these myriad of programs that all look good on the surface, but may not be impactful after all.
Wow, that's really distressing. I mean, it does connect to the stigma piece. I'm thinking about, we're just supposed to know how to parent. It's right? Culture tells us that we know how to do this, and so to some degree there's an admission, maybe I'm not equipped to do that, so it gets back into that other part of stigma too, just on a different level. Wow, okay. Nick, let me slide to you, and then I do want to open it up. A promise I will keep. Yolanda has mentioned what her health system is doing, I mean, her localized one. In general, is the health system set up to address the complexity of this crisis, and what could we be doing better, particularly in rural communities?
So the U.S. healthcare system is a deeply challenged one. It is challenged at the level of access, it's challenged at the level of cost, it's challenged at the access of quality. The old idea was that we spent way more, but we got so much more, and that is simply not true when you look at the data. So it does appear that the healthcare system is what we would call a structural determinant. We have social determinants, and once again, I generalize, but we can zoom back into individual counties in Indiana, if you like. There is clearly a economic, social dislocation, often rural, that gives rise to what researchers call the diseases of despair. It can be addictions, it can be suicide, depression. The statistics are very strong, the correlations are very strong. If you sort of look at a heat map of economic distress in the country and layer on top of that the opioid overdose deaths, there's a rough correlation. If you then go from social determinants to structural determinants and you layer another map on top of that, which is healthcare system performance, again, it looks roughly the same. Structural determinants, maybe these folks don't have insurance. Maybe the stigma attached to this has influenced them so much that they believe that around every corner there is a police officer who doesn't believe that this is a chronic disease and instead believes it's a moral defect. There are enormous problems trying to identify solutions. Even as we go into county data, your data that you showed, Faith, was up to date, I think, as far as the county by county deaths. The new data that I saw just last week was health outcomes on a county by county basis in Indiana. There is no pattern, right? You might just as well have given the map of Indianapolis and asked your 4-year-old to color in different counties. I mean, you can make some rough guesses. Yes, Scott County is always going to look bad, sort of thing, but there is no real pattern. Urban, rural, suburban. We just get different phases of different types of addiction. I mean, we're currently in our sort of third opioid phase, right? We had prescription opioids starting in the sort of 2000s through 2010 started to sort of really move up. The second phase, heroin overdoses, sort of tracks that roughly, and then around 14, 15, we see this massive spike in the deaths attributed to fentanyl. And so we have different crises, different addictions crises occurring in different time frames in different places. It's very hard. I can tell you that there are places in the country that have made progress. If you want to see how you can make a prison and jail system work for persons with overdose, with substance use disorders, you need to go to Rhode Island, where they have all 3 types of medication-assisted treatment are available in the prisons and jails. Only 5% of jails, of prisons in the country offer all 3 types of medication-assisted treatment, which is the standard of care. Jails generally offer none. In jails, you just have withdrawal. If you want to see how our healthcare system can work, you probably need to go to Vermont, where they've built a really good hub and spoke model specifically to deal with substance use disorder. And so you have these sort of little areas that bubble through. That maybe some of the police forces, for example, in Illinois and Massachusetts have developed alternatives to arrest. And instead they will use their facilities to counsel people and get them into treatment. And that's a really positive sort of approach.
So there are sort of, I don't want to say isolated, there are pockets of success, but the whole picture has not yet been put together real well.
Correct.
Let me open it up to y'all. Your observations or questions to anybody on the panel. I have questions that I can continue asking, but I want to make sure you get the chance to ask anything. So Kyla is walking around with what looks like a red box of Kleenex, but it is in fact a microphone.
It is in fact a microphone. It's technically made to be tossed, but my athletic inability, I'm gonna carefully hand it over.
Okay.
Hi.
Hi.
So I want to go back a ways in conversation to one of the things that that came up when we started talking about impact on infants. And I'll be honest, right, like George is on my mind, the way that we are increasingly good at governing bodies and less good at governing communities is on my mind. And so I'm wondering what it looks like to support infants by supporting women who might become pregnant, and how you do that without damaging their autonomy, how you do that, you know, and maintain compassion for them as individuals. And I'm wondering how that's complicated by access to abortion and what that looks like in the communities where you're doing your work.
That was an easy first question. Thank you so much.
All right, I'm trying to think about it.
Thank you, Yolanda, for taking that microphone.
See what I can do with this one. So we know that many pregnancies are unintended pregnancies. And so there's a lot that can be done legislatively that's not being done right now. Something that, I don't know if you're aware, but in Indiana there are 73 rural health clinics. And rural health clinics and community health centers like FUHCs are not reimbursed for supplies. So the long-acting contraceptives like IUDs and Nexplanons, $600, $800 for a clinic to purchase those, and they would get paid about $75 to put that in. Legislatively, that makes no sense. So things could be done at a structural level that could be very impactful. In terms of her supporting a mom who before she's pregnant, I think ultimately what I would say is paying attention to all different facets of who she is, and especially paying attention to mental health, since that seems to be probably one of the most impactful ways that we can address her needs. So we started about a year ago at performing depression questionnaires with everyone that's there for wellness, or even now beyond wellnesses. And so we were a little skeptical at first of giving someone a piece of paper and having them fill out, and like, would they really be serious about it? And it has opened up so many conversations. Invariably, our days and visits are much longer now than they had been just by making that one move, but it's something that makes a big difference. So those are the kinds of things that by paying attention, by being seen in a therapeutic relationship, it can make a big difference. And then particularly in addiction, getting resources for treatment. Something that our community has done recently is a group of individuals opened up a recovery engagement center that is there purely as a resource for people with addiction. And some of the people that staff it have been in recovery themselves, because we know that relationships with people who understand, whether they be peer recovery coaches or just someone who's walked the walk, have been really effective. And two of our community members at this front table here had opened up that Safe Haven Recovery Engagement Center, so that moms, before they become pregnant, now have access to services by someone who understands. Recovery meetings, a recovery community are all part of that.
So I just want to say, actually, your question spoke to my very soul. It is something that I struggle with and think about all the time, because it's me alone with my computer, like doing mathematical algorithms, right? Like, I'm crunching numbers and doing data, and I don't get to see the impact of where this research goes. And one of my fears is that they're going to use it to punish women, right? Rather than what I hope is that we'll have a more holistic approach. We'll see women as people, not just baby makers, and like we'll start earlier with like, hey, how's your mental health? What substances are you using? Do you need birth control, girl? Like, I struggle with that deeply, and if someone wants to help me like learn how to balance these things out, because I still think the numbers and the research and the science has to be out there, but we also have to have people who are, I think, perhaps smarter and better at speaking than me, help people interpret the data and use it in the correct way. So, yeah, you hit on something so deeply important that I don't even have time to unpack it, but thank you.
So it's clear that we do not have a healthcare system that works for all. We continue to discriminate against women. We discriminate against persons of color. The availability of buprenorphine, probably the most common medication-assisted treatment, the availability of that to persons of color barely moved over the last few years. White people were 35 times more likely to gain access to the drug. There are bright areas, right? Not in Georgia or Alabama. The Affordable Care Act made preventative care free for children and for women and for men. And that included free contraceptive services. They have to be defended in today's world against them being taken away. Those free services are also part of Medicaid. We have known that since the Surgeon General's report in 2016, that the single best approach, or the single biggest mileage we could get in dealing with the opioid overdose crisis was Medicaid expansion, right? Which a large number of states, 14 states, still have not expanded, the largest being Florida and Texas. Let us all cheer, therefore, that we have expanded Medicaid for Indiana. But before you cheer too loud, the proposal is now to bring in work requirements or other social engagements. There is no data anywhere that suggests that making work a requirement for Medicaid will improve anything. It certainly doesn't improve health. All the data goes the other way. If people's health improves, they will find work. There is also an extreme likelihood that the cohort that would lose Medicaid with a work requirement will overlap quite considerably with the folks who have addictions crises. The numbers that we're seeing in the states like Arkansas, where this is now ongoing, are frightening as to the number of persons who are losing their medical need. You mentioned mental health. We are in a world where apparently there is mental health parity as a matter of law. Well, that's fine, but try and find a mental health provider. Particularly try and find a mental health provider that's within your network. Try and find an addictions provider that is in your network and that therefore you can afford. So we have massive access and cost problems that we haven't even begun to dig into. Maybe with Medicare for All, I don't know.
Other questions or comments or insights? Don't leave it up to me, folks. I've got a long list. Thank you.
Wait for the box.
It's the speaking box, the talking box.
It's the validation box.
Thank you. Earlier you were talking about opioid overdoses, and I was wondering, you mentioned that the percentage of overdose deaths went down in 2018, so I was wondering what that was. And then also, from being out in the community and hearing some people talk about the opioid overdoses and how they feel like the numbers are rather low. And I heard someone said something one time about if someone, especially around the borders, like, for instance, Clark County, Indiana, and they go over to Louisville, and then that is where the overdose happens and the death happens, that it's not calculated and counted for Indiana. So I don't know if you could speak to that.
There is certainly some bad data. You mentioned this, Doctor, in the context of stigma. We know that the coroner's data was pretty deficient, particularly up to a couple of years ago, because there was so much stigma that the physicians would not put down opioid or overdose as the cause of death. Closely knit communities and so on. So there's definitely issues there. I think maybe one point that we haven't touched on that I think comes out of that and maybe is worth mentioning is what it means to move from a prescription drug crisis to a street drug crisis. If you ask policymakers at the state or federal level, agency people, or if, like we do, we scan grant proposals and stuff like that, RFPs, asking people to do research, you keep coming across prescription drug monitoring programs, which is INSPECT in Indiana. And everyone wants to talk about prescription drug monitoring programs. Why? Our problem at the moment is fentanyl, which is quite hard to get a prescription for. So we're putting all of this money, all of this time and effort into really dealing with a crisis that at least has leveled off so far. Yes, there was overprescribing. It was bad. Some of it led to the use of street drugs. But we put an amazing amount of energy into something that is pretty much over. Worse, if you put all your energy into cutting back prescription drugs, you will, one, undertreat people with pain who need them. It's a legal, federally approved drug that, when properly prescribed and the patient properly monitored, we need in our national formulary. Secondly, you will push people from prescription drugs to street drugs. And so long as opioid overprescribing is the only problem we see, or the only problem we care to cure, then prescription drug monitoring will be the solution to everything. But that's not our current problem. Our current problems are far more diverse.
Thank you. I'm being told by the lurking director over there that we're out of time. Let me just throw an email out your way before I thank our panelists. grandchallenges@iu.edu. We would love to hear from you if you have thoughts, partnerships, ways that we can help you in your communities, or if you want to just learn more about the research we're doing, please let us know. My thanks to Nick Terry, Angela Campbell, and Yolanda Yoder. Thank you so much.
And our thanks to you, Faith, and to Grand Challenges for your incredible partnership. We are ready to move into our next breakout sessions, and I think Dr. Yoder put it quite nicely when she was referring to how you treat patients. You treat the whole person, and indeed what we're finding at the center and what you as community leaders already know is that we have to build the whole community. And as you are engaged in conversation and learning today, if you have ideas for what your community needs and what some possibilities are, I encourage you to talk to one of us with the red stripe on our name tags from the Center for Rural Engagement. We're eager to respond to your ideas and to new initiatives. So thank you for being with us. A quick announcement. Unfortunately, Brian D'Onofrio is ill today. And so we're needing to cancel the computer adaptive testing session at 2 o'clock. So if you're planning to go to that, I encourage you to go to one of the other 2 workshops. And we are moving the INROC Consortium workshop now into the Ford room. So if you're going to that consortium workshop, it'll be in the Ford room at 2 o'clock. But there are exciting and engaging workshops right now at 1 o'clock. Thank you for being with us.